Hello there, and welcome back. This is part 4 in a series of bone healing and pathology, important board review material for any dental boards. As always, I refer to White and Farrow's Oral Radiology, so if you haven't gotten that text, you definitely should. Crack it open, read it if you haven't. This slide is right from that text. We're talking about the pathways of vitamin D, from the pre-vitamin D to formation of the active form of vitamin D, also its effect on calcium and phosphate, and their subsequent effects on the parathyroid hormone and how all those affect bone. So really important for understanding the underlying mechanisms behind some of these other diseases that I'm going to talk about in subsequent lectures. So let's start in the beginning. In the beginning, there's light, specifically sunlight. We know that sunlight has UV rays, specifically UVB rays, are what cause a change in our skin. We have a protein called 7-dehydrocholesterol, or 7-DHC. And because of these UVB light, that is changed to pre-vitamin D, not the active form of vitamin D, but we're going to follow all the different steps. And then this is a long process, that pre-vitamin D over time through a slow reaction in our bodies that becomes vitamin D3 or cholecalciferol. This is the same vitamin D that we get through most of our food sources. So foods like fish, specifically salmon, redfish, mushrooms, and sometimes vitamin D fortified substances like milk. And this is still not the active form of vitamin D, but it's the most common form that you're going to get out of your diet. And so to become the active form, the vitamin D3 has to undergo 2 transitions. And this is done by different enzymes. The first one in the liver, this 25-hydroxylase, that's an enzyme that's going to add a hydroxyl group, an OH, at the 25 location of this vitamin D3. And so if you have a healthy liver, that's going to convert some of this vitamin D3 to what we call 25-OHD. So it's vitamin D with the hydroxyl group at the 25 location. And what this means down here is this is found in high concentrations in the blood. This is kind of like the reservoir inside the blood for vitamin D. Very easy to measure. And in fact, most of the blood lab values that they do, they're going to measure this component right here and not actually the active form. So we need one more step before becoming the active form, and that's done in the kidneys. And so that adds a hydroxyl group to the 1 location on the vitamin D molecule, or 1-hydroxylase. So we have to have functioning liver as well as kidneys to get the active form of vitamin D in our system. And that's called 1,25-OH2 vitamin D, or calcitriol. Now, they do have medications that have this. They're going to be expensive. It's harder to produce. And then also, as I said, lab values are mostly taken from this one because it's easy to test for. It's in high concentrations in the blood. This one, the active form of vitamin D, is actually present in low concentrations in the blood, and it's really tough to test for. They can do it, but it's more expensive. So your typical vitamin D test is going to show 25-OH, which is not actually the active form. That's, I guess, assuming that you have healthy kidneys. So if you have sufficient 25-OHD, you're going to have sufficient amounts of 1,25-OH2D. So what is this, the active form of vitamin D, actually do in our systems? Well, the first thing we want to talk about is bone turnover. A lot of books talk about this as increasing bone resorption, which is a little bit counterintuitive because you think of healthy vitamin D levels leading to healthy bones. So you don't really think of it as resorbing too much. And so the way I think of it is that it does help resorb it, but it leads to healthy bone turnover. And as long as you have adequate amounts of calcium and phosphate, that's going to be healthier for your bones. You know, bones are supposed to be able to turn over. Having healthy bones means having a healthy turnover of minerals. And so at times calcium and phosphate are being resorbed, but at the same time they're being laid down. So that's how our bone responds to stress. As you're building up muscle, you're actually strengthening your bones because it's able to resorb some of the previous bone minerals and lay down new minerals. So this is an ongoing process, and your bone is constantly being turned over. And so healthy amounts of vitamin D is actually healthy for bones. As I said, inadequate amounts of those minerals that you need, calcium and phosphate. And then another effect of this active form of vitamin D is increasing calcium resorption in the gut. What that means is you're getting more calcium from the same amount of food that you're getting inside the gut. It's just able to resorb more or retain more of this calcium. So that increases calcium levels. Another thing it does, so this negative arrow means it inhibits. So this is inhibiting production of vitamin D. So it's a self-inhibitory process. It inhibits the production and the activation of this 1-OH enzyme that we talked about. What that means is you maintain concentrations of this 25-OHD in the blood, but if you have enough of the active form, the 1,25-OH2D, it's going to inhibit its production by that last step in the kidneys. And then the last effect is its effect on the parathyroid glands, and I'm going to talk about parathyroid hormone in a minute. But again, a red arrow, a negative sign, this means an inhibitory effect of the parathyroid hormone production in the parathyroid glands. And so now I want to talk a little bit about calcium, right? That's a big part of what we want to talk about today. And calcium is really important, not just for the bones, but for every cell in the body. Normal calcium levels are important for muscle contraction, for nerve transmission, and more. And so that's why they're very tightly controlled in the body. Calcium levels in a healthy person are not going to fluctuate very much. And if they do go too much out of normal, that's going to cause some drastic effects. I'll talk about that when I talk about other diseases like hyperparathyroidism. And so what's the primary thing that controls these calcium levels? Well, enter PTH. And now I want to talk a little bit about PTH, or what I like to call the calcium Nazi. Little throwback to Seinfeld episode, the soup Nazi. We'll talk a little bit more about that. But PTH is kind of the calcium regulator. It makes sure that calcium never gets too low in the blood. So if calcium ever starts to get low, you see this inhibitory effect of calcium, that causes an increase of production in PTH. That PTH, that causes resorption of bone or bone turnover. It starts to draw these minerals out of the bone. And so calcium is going to rise. So again, if calcium ever goes low, it raises the PTH levels, and that in turn raises the calcium levels because it's drawing it out of the bone. It also concurrently is going to draw more phosphate out of the bone, which you can kind of think of as a side effect because the primary reason it's doing it is to increase the calcium levels. And so the other thing it does, you see it has an effect on the kidneys as well. It wants to raise the calcium levels. It's going to promote that last step of hydroxylation of vitamin D to create more of that active form of vitamin D. We said vitamin D also increases bone turnover, so that's going to affect calcium. So it has all these different effects, but primarily its function is to increase the calcium levels. And so this I just mentioned, activating that last hydroxylation step in the kidneys. But also, it has this secondary effect on the kidneys. And what that does is it increases the calcium reabsorption in the kidneys, meaning urine does not excrete as much calcium as it would otherwise. And I think of this as kind of doing it at the expense of phosphate, because you notice when this is hyperactive, in the case of hyperparathyroidism, phosphate levels actually go down. And so I think of it as holding on to calcium while excreting more phosphate. All right, so that's it. I know it's a lot of information on one slide, but we'll go through these different hormones and minerals one at a time here. So let's first talk about what is vitamin D's function. What was its function on intestines, if you remember that? And it had an effect on calcium as well as phosphate, but it promotes calcium and phosphate absorption inside the intestines. And what about the effect on kidneys? Well, I didn't mention this in the previous slide, but it does decrease calcium renal excretion, so similar to PTH. So it makes the kidneys hold on to more calcium than they would otherwise. And the effect of vitamin D on bone? Well, I said it increases bone turnover. Some texts talk about it increasing resorption, which it does. It activates the osteoclasts. But I think of it as increasing the bone turnover because in healthy amounts of calcium and phosphate, this is going to be healthy for bone. You should have healthy bone turnover. And its effect on itself, well, it does have a self-inhibitory effect. It inhibits that 1-hydroxylase activation in the kidneys, which inhibits that last step of formation of the active form of vitamin D. What about parathyroid glands? We talked about parathyroid hormone, and this inhibits PTH production. PTH is the hormone you may think of as being bad for bone overall. If it's too high over a long period of time, that's going to cause resorption. And so you can remember the vitamin D being healthy for bones, it is going to inhibit too much production of that PTH. So that might be one way to help you remember it. All right, as a review of another one of the hormones, which is the one I talked about as the calcium Nazi. So similar to the soup Nazi here. But instead of saying no soup for George, he's saying no calcium for the bones, and that's the parathyroid hormone. And so the main thing this does is going to draw calcium outside of the bones. And so that answers this first one. What is the PTH effect on bone? Well, it directly increases bone resorption. And the idea of that is to increase serum calcium levels because we always want to tightly control those calcium levels. All right, and what about the kidneys? If you remember that one, that does increase reabsorption of calcium in the kidneys. I think of it as at the expense of phosphate. So it maintains as much calcium as it can, but as it's doing that, it's expelling more phosphate. It also promotes that last hydroxylation step in the kidneys, so hydroxylation to the final active form of vitamin D. What about in the parathyroid glands? Well, there's a self-inhibitory method, and that's through calcium levels. As PTH increases those calcium levels in the blood, those calcium levels in turn are going to reduce the production of PTH in the glands. All right, one last one here, and that's alkaline phosphatase I want to talk a little bit about. This is an enzyme that removes phosphate from carrier molecules, making it available for bone mineralization. And so really active during osteoblastic activity. So any disease that's going to increase bone turnover, and even in fracture healing, that's going to cause an increased level of alkaline phosphatase, or ALP. What it's really known for, though, is being really high in Paget's disease. And that's a really common board review question. You may have other normal values or close to normal values, and then just a super high ALP level. That's kind of classic for Paget's disease. But it's also going to be high in these other diseases: rickets, osteomalacia, hyperparathyroidism, multiple myeloma, metastases, so malignancies that have metastasized to bone, and those will increase bone turnover. So there are a lot of diseases that do it, but this is the one, Paget's disease, that it's most well known for. All right, that does it for these mineral and hormone pathways. Hopefully that'll help you understand as we get into the mechanisms behind some of these diseases we're going to talk about now.